I'll just take you to another part of the viral corneal ulcer. It is there, I mean, for the past 8 to 10 years, people are getting aware of it. And now this awareness has come more, especially when you think of a case who was HSV to begin with. But if it is not responding to your conventional treatment, that's the time when you start thinking in terms of CMV endothelitis. So we recently had a case, though one knew about it, this is the second case I've seen, whom we diagnosed CMV endothelitis only after we had done the cataract surgery. So this was our mistake, so I just wanted to share with you. So we're reporting a case of a CMV endothelitis post-phaco in an immunocompromised patient. This was a known case of HIV who was on heart and had immature senile cataract in both eyes. We did the phacoemulsification in this patient, and then I'll tell you the story. I'll walk you down the story. And the CMV infections, they have been reported in a lot of immunocompetent patients, but not many have been reported from patients who've got HIV. Though CMV retinitis is very well known, but CMV endothelitis has not been reported in AIDS patients. The different manifestations, the anterior segment manifestations of CMV could be endothelitis or a recurrent anterior uveitis, or it could be in the form of Hooke's heterochromic cyclitis or a Posner-Skolsman syndrome, where patient lands up with very, very severe high pressure. And maybe if you really look at the cornea, make a little broad beam, you might see small coin-shaped lesion, but if you've done a diffuse examination of the cornea, you're likely to miss it. So, CMV endothelitis post-ocular surgeries have been reported, but not in a case of an immunocompromised patient. So this was a 46-year-old woman who was diagnosed case of AIDS on heart, and she presented with diminution of vision. BCVA was 6/60 each eye. She underwent an absolutely uneventful phacoemulsification in the right eye with universal surgical precaution. On the first post-operative day, the vision was 6/9 with absolutely clear cornea with very minimal anterior chambers reaction, and she was started on routine combination of galifloxacin and prednisolone. I mean, I'll tell you where we've erred, so we'll walk you down that. On the fourth post-operative day, the patient presented with decrease in vision to 6/60. On closer examination, of course, we noted diffuse corneal edema. There were present keratic precipitates. There was minimum anterior chamber inflammation. And on dilated pupil, of course, there was no evidence of vitritis. Pressure was 21. And posterior segment examination was absolutely normal. My resident had done this case, and he tried discussing with me. Of course, I had no clue what I was handling. The patient was started, the topical prednisolone was increased, and of course hypersol was added. While on the 7th post-operative day, the patient had further decrease in the vision to 1/60, and patient had dense diffuse corneal edema in the right eye. And on closer look, when I really made the broad slit, I noted that patient also had coin-shaped lesions on the epithelium part, and that is the time I reinforced what Manisha was trying to say. We looked at the fellow eye. When I looked at the fellow eye, we saw there were diffuse superficial coin-shaped lesions which were present and which probably were missed preoperatively. So this is what I'm trying to show you. This was a patient on the 4th post-operative day. You can see the edema, and on the 7th post-op day, it had worsened. ASOCT you can see the corneal thickness markedly increased, wavy endothelium, and there were multiple pigment or maybe keratic precipitates which were seen at this time. It's like we've already reached the 7th post-op day, and then we started thinking, what is it that I'm dealing with? Still I wasn't too sure because I hadn't seen CMV endothelitis by that time. Whether is it TAS or is it some DMD which we missed, but ASOCT did not reveal that. Then when I reviewed the literature, and also when we saw the fellow eye had multiple corneal lesions, we started thinking in terms of CMV endothelitis, and we took the aqueous PCR. On the quantitative PCR examination, we could get CMV DNA copies were there. So the DNA was there in the aqueous, and it was negative for HSV. That is the time when we made the diagnosis of CMV endothelitis. Send the patient back to the people who were treating her with heart, and with the confirmed diagnosis of CMV endothelitis, the patient was put on IV ganciclovir, 200 mg BD twice a day for 14 days, and then also along with it we gave topical 3% ganciclovir gel 3 times a day. By the 10th day of the systemic ganciclovir, the edema started reducing and vision improved to 6/18. Patient has been continuing on oral ganciclovir 900 mg daily for 3 months along with heart, and this is what I can see, that patient has recovered to this level. What is a little worrying, that in the inferior 1/3 of the cornea there is still persistent endothelial failure, and this corneal edema has not resolved, and this corneal thickness you can still see is increased. I have a feeling this patient is probably now waiting for DSEC, this edema probably is not going to resolve. So start thinking cases of CMV. If you thought a case was initially HSV and does not respond to your conventional treatment, that's the time when you should start thinking in terms of CMV endothelitis. And also, if you look at the broad beam and very multiple superficial lesions, intervening cornea clear, they're coin-shaped lesion which were typically described as a nummular keratitis. Again, that's a clue. Now the patient is waiting for phaco in the left eye. By now, with IV ganciclovir and everything, the left eye coin-shaped lesions have disappeared. But when I'm going to do phaco, I'm definitely going to give a prophylaxis with oral ganciclovir. I've discussed with some other people for how long ganciclovir should be given and everything. I don't have an answer. If you can give me an answer, so I don't know if that how long one can be on ganciclovir and what's the regimen patient going to be followed when she undergoes a phaco in the left eye. And so the concluding line here is that there has to be a prompt and early recognition. Like here, we let the inflammation went on for nearly 2 weeks and we ended with endothelial failure. Had we recognized it within a week or maybe preoperative, maybe we could have avoided the endothelial failure in this patient. And I'm just quoting, though there are multiple other studies available, but this is one of the studies which has just appeared in Jan 2015 of BJO, which talks about the clinical features and management of cytomegalovirus virus corneal endothelitis, and they have analyzed 106 cases from Japan corneal endothelitis study. They have concluded that the commonest sign, when they saw the patients, they were diagnosed as anterior uveitis or ocular hypertension prior to making a diagnosis of endothelitis. And coin-shaped lesions were observed in 70.6% and linear keratitis precipitated in 8.3% of the patients. 95% of the cases were on anti-CMV drug. The conclusion was that CMV endothelitis is the most common in middle-aged elderly men. It should be suspected when patient present with endothelitis involving coin-shaped lesion accompanied with anterior uveitis and ocular hypertension. Till now we've been talking about high IOP in viral necrotizing keratouveitis also. So here also you get the similar picture, and they have given the diagnostic criteria. This is being followed by the Japanese ministry for cytomegaloendothelitis. First criteria is that they have to have a viral examination by PCR of the aqueous positive for CMV DNA but negative for HSV DNA and varicella zoster. The typical, they get endothelitis with coin-shaped lesions or linear KP similar to the rejection line we are used to seeing, Corrados line. The atypical manifestation is when they have localized corneal edema with KPs with 2 of the associated signs like recurrent uveitis, ocular hypertension or corneal endothelial loss. So this is the way they have classified as typical CMV endothelitis and atypical CMV endothelitis. But the response is very good with ganciclovir when diagnosed in the early stages. That's all I want to say. Thank you very much.